All right, so thank you all so much for being here and joining us to talk about HPV and ways to prevent 6 types of cancer in the future for various types of patients. Again, my name is Christina Sire. I'm with the Iowa Medical Society and the Iowa chapter of the American Pediatrics. Um, and I just have a couple of housekeeping things to go through before we get started here. So for the didactic presentation, if you could please remain on mute and to either raise your virtual hand or to drop something in the chat, as I will be monitoring that for today's session. This is our CME information, and your credit will be received within 6 weeks of today's date or sooner. And I will provide an evaluation link at the tail end of this presentation and in a follow-up email to gather feedback and additional ID topics for the future. This is our disclosure form, and Dr. Kaushik will have her own as well, but this is to cover the entire webinar, which is supported and funded by the Centers for Disease Control and Prevention and the American Academy of Pediatrics. And I have the pleasure of introducing our speaker today, Dr. Ashlesha Kaushik. I know that she has a myriad of accolades, and I'm going to attempt to summarize in a very short paragraph, just so that we have time to get through everything. And Dr. Kaushik serves as the Medical Director of Pediatric Infectious Diseases and Director of the Antimicrobial Stewardship Program at Unity Point Health St. Luke's, and also holds an academic appointment as Clinical Associate Professor of the University of Iowa Carver College of Medicine. She serves as the Vice President and President-elect of the Iowa chapter of the American Academy of Pediatrics and became the first physician from Sioux City to hold this position. She's a board member of the Iowa AAP, a national spokesperson for AAP, and recipient of numerous honors, including the 2019 CDC Childhood Immunization Champion Award and multiple AAP awards for service and education. She has been elected for several professional organizations and committees, which I won't go into detail. You can see some of them on the screen there, but feel free to follow up and we can walk through all the things that she's accomplished. Oops, I scrolled too far. She is also serves as the Iowa Chapter Infectious Disease Champion and chair of its Infectious Diseases Committee. And in addition to publishing and serving as visiting faculty at Harvard, she holds a Master's of Science from Harvard Medical School and has been recognized as a global health expert by the Saban Vaccine Institute. That is everything that I have. So I'm going to go ahead and stop sharing my screen, and I'm going to hand it over to Dr. Kaushik.
Thank you so much, Christina, for the lovely introduction. And I'd like to share my slides. So just let me know if you can see them. Perfect. So today we'll be talking about HPV, and I'm honored to give this webinar on behalf of Iowa chapter of American Academy of Pediatrics and to go over HPV vaccination, the recommendations from the CDC as well as the AAP, and also how to get about effective conversations regarding vaccination with parents. I would like to dedicate this webinar to the fond memory of Dr. George McCracken. He was one of the pillars of pediatric infectious diseases. We lost him recently, last month. And a section on infectious diseases from American Academy of Pediatrics is also going to release his memoriam. So I was fortunate to be one of his fellows. And this is me in the picture with him on the right. But it's just very sad that we lost him. But he was the founder editor of the Pediatric Infectious Disease Journal, which is like the pillar or, the landmark journal, the flagship journal for PEDS ID. So just commemorating him. All that we know as his fellows is because of him. I think we owe a lot to Dr. McCracken. So thank you so much. We miss him. I have no financial disclosures for this talk. And the objectives, as we had mentioned on the brochure as well, are to talk about the clinical evidence on HPV transmission, as well as, the clinical presentation and the clinical updates on the disease, the epidemiology and the associated disease burden. Also, to talk about the CDC and the AAP guidelines for the HPV vaccination and how we can effectively counsel patients and parents about HPV-related risks, as well as the benefits of vaccination. So as we are mostly familiar, HPV infections are extremely common. And it is said that almost all adults might have acquired HPV during some time in their life. And the good news is that HPV mostly becomes undetectable within 22 years. So 90% of the infections become undetectable, and most of the patients, they are able to be have this infection, but then become undetectable. 10% are the problematic cases in which we do have serious consequences, and that's what's worrisome. And the more I was planning to present this and talk to you about this, the more concerned about the various manifestations I became. Like, it is really serious. It's not a simple thing to just say, hey, it's a cancer-causing virus. The cancers can be really, really serious and bad and really lead to high mortality, as I will show you in the data. So HPV actually is a DNA virus, and it has cutaneous and mucosal types. Cutaneous types are usually positive for the common skin warts, plantar warts, flat warts, etc. But mucosal types can be divided as low risk and high risk. And the low risks are the ones that cause papillomas of mucous membranes. But the high risk types are the ones that cause the precancerous as well as the cancerous lesions. And the cancers are not just confined to the anogenital tract, they also cause oropharyngeal cancers. So cervical cancer is the most common HPV attributable cancers in females, and oropharyngeal cancer is the most common HPV attributable cancer in the male population. And actually, it is the most common HPV-related cancer overall in the United States. It's extremely unfortunate that we are still seeing a vaccine-preventable disease as the cause of the most common oropharyngeal, cancers. The low-grade squamous intraepithelial lesions and the high-grade intraepithelial lesions are also the result of long-term anogenital colonization with HPV. And as you know, these are histopathological terms, and they are usually detected by pap smears, that is by cytologic testing. And then sometimes we might resort to tissue biopsy to make the diagnosis of CIN, which is cervical intraepithelial neoplasia. And these are precancerous lesions. And over a period of time, which spans over decades, they will lead to serious cancer, full-blown cancer. What are the other manifestations of HPV? So apart from warts and papillomas, we have something called recurrent respiratory papillomatosis. And I have seen a case in a kid, and it's very, very, striking when you see one. It's a very rare condition. It is characterized by recurrent papillomas in the larynx or other areas of respiratory tract. And usually the types that are responsible for this are HPV type 6 or 11. And then you have two varieties, either juvenile onset or adult onset. Juvenile onset usually occurs before 12 years of age and usually is resultant from vertical transmission at the time of delivery. And it can cause respiratory tract obstruction and maybe requiring repeated surgeries, and usually managed by ENT personnel. AORPP, as you know, AORRP, is like the adult onset. It usually occurs after 20 years and is usually related to sexual behavior. Also, another rare condition, which is caused by HPV, is called epidermodysplasia verruciformis, which is a rare inherited disorder. And it is created by a deficiency of CMI, which is cell-mediated immunity. And this will result in an abnormal susceptibility to certain HPV types. And that manifests as chronic cutaneous lesions. Over a period of time, these also transform into malignancies, and it occurs in as many as 30 to 60% of the affected population and usually occurs over the next few decades. So no matter what, HPV can look very benign on surface. Some of these lesions, even if they look like warts, they might progress to cancer. So it's a very dangerous cancer-causing virus, and we must not ignore the fact that so many people are affected by it. As I can show you on this slide, HPV is the most common STI in the United States. I was hoping to see syphilis over here, and I was looking up the statistics, but no, HPV. 42 million people are infected with disease-causing HPV, and 13 million people acquire a new anogenital infection every year. So the genital tract is affected in almost 1/3 of the population. In females, the highest prevalence is seen in the 20 to 24-year-olds, and this is also reflected in the current guidelines for screening, as we'll go over. And the risk factors, as you can imagine, will be higher lifetime number of sexual partners, earlier age at sexual debut, and then also immunocompromising conditions, including HIV infection. All immunocompromising conditions make HPV worse and also increase the risk of progression to malignancy. The groups disproportionately affected, unfortunately, include the transgender, the LGBTQ segment of the population. And genital infections are usually transmitted by intimate sexual contact. But also, HPV is transmitted perinatally, although rarely. And anytime you see HPV infection in a neonate, vertical transmission should be considered. But anytime you see any types of anogenital warts in a child, you must consider the possibility of sexual abuse. What about the non-genital hand and foot warts? Well, they occur commonly among school-age children, and their acquisition is usually through casual contact and is also, triggered by minor skin trauma. And as you can see, auto-inoculation plays a big role in the pediatric population. So why are we so worried about HPV? Because the statistics are alarming. HPV is the leading cause of cervical cancer and oropharyngeal cancer in the United States. HPV attributable cancer causes approximately 4,000 deaths annually in the US. And then oropharyngeal as well as cervical cancer, they account for more than 1/3 of HPV attributable cancer cases per year in both females and males, respectively. HPV is the cause of at least 90% of all cervical cancers, so the number one cause, as well as 70 to 90% of all oropharyngeal cancers. And most of the other cancers like vulva, vaginal, anal cancers, etc., are also attributable to HPV. The CDC, if you open up the website, it says about 47,984 cases of cancer are found in parts of the body where HPV is often found, and HPV directly causes more than 30,000 of these cases. This is data from Iowa, and as we can see, we are slightly higher than the national average as far as cervical cancer rates go, and also higher than the national average as far as the oropharyngeal cancers go. So the rates are rising and the virus is not going anywhere, right? So we need to protect. So is there anything we can do to help? Yes, we can. Vaccination is the biggest preventive measure that we have against HPV. And we'll talk about that. But first, let's talk about what are these viruses actually. So they are small, non-enveloped, double-stranded DNA viruses. They belong to the Papillomavirinae family. And more than 200 types are recognized, but the disease-causing types are less than 50. And so there are like around 40, which are considered to be the disease-causing, serious disease-causing types. Type 6 and 11 mostly cause anogenital warts, including condylomata acuminata, and also recurrent respiratory papillomatosis, as we saw. So 6 and 11 are mostly associated with warts, but the high-risk types, especially 16 and 18, 16 and 18 are the big ones that can be associated with all kinds of precancers as well as invasive cancers. Approximately 50% of cervical cancers are attributable to HPV type 16. And then if you talk about 16 or 18, they make up majority of the cancer-causing varieties. In fact, the anogenital cancers as well as oropharyngeal cancers are also attributable to HPV type 16. So this is the big one. The risk of developing cancers is greater in people with certain immunocompromised conditions, as I mentioned, especially HIV. And that's why the screening recommendations for HIV patients are slightly different, as we'll discuss. And for most part, most infections will remain subclinical, and in 90%, as I said, they will clear spontaneously within 1 to 2 years. But it's very difficult to predict who will clear and who will not. And then in those 10% of the remaining patients is where we see all the manifestations. Cancer is an uncommon outcome, but it requires decades of persistent colonization with high-risk HPV types. The high-risk being the ones that I mentioned here. So 16, 18, 31, 33, there are around 14 of these which are considered to be high risk, and a number of them are covered in the vaccine. 16, 18, 31, 33, 45, 52, and 58, I believe, are covered in the vaccine. So the incubation period for symptoms is usually in a period of months, but the period of neoplastic changes, the time that it takes to develop those is usually many years to decades. So that gives us a window for screening. And that also gives us a time frame, since they are occurring after 20 years mostly, that gives us a very good window to also prevent these infections in our adolescents and our pediatric population. So what are the routine cervical cancer screening guidelines? So, we'll go over those, but just so only for cervical cancer do we have routine screening guidelines. Although it has been attributed to cause so many other anogenital cancers, there is no routine screening recommendations for cancers at these sites. So even underlining the importance of prevention even more. In fact, if there is, a doubt about any precancerous locations or, any conditions like that, then we have to do biopsy and we have to make the diagnosis histologically. And moreover, if you are attributing HPV to these, then identifying the presence of HPV surely requires detection of viral nucleic acids. So it's a cumbersome process. It's a long process, even detection and diagnosing these, because sometimes they can just cause very, very non-specific and some symptoms of pain or discomfort, but really, they might come to light decades later when it's too late. So that's why CDC, insists that we have cervical cancer screening guidelines. From ages 21 to 29, screening should begin at age 21. And they usually say that pap smear or a cervical cytology test every 3 years should be done in this age group. Over ages 30, so for ages 30 to 65, we have three options. Either they can undergo pap screening every 3 years, HPV test alone every 5 years, or else co-testing with pap smear as well as an HPV test every 5 years. And over 65, if a person has had consistently normal screening results, no history of any precancerous lesions, etc., then the woman may not need further screening. Now, for HIV-infected and immunocompromised patients, the screening criteria are a bit more stringent. So whenever they begin sexual activity, HIV-infected adolescents should have the screening performed twice a month at 6-monthly intervals during the first year after diagnosis of HIV infection. And if the results are normal, they can go for annual checkup thereafter. So it's like for immunocompromised patients, including organ transplant recipients and HIV patients, we need to have very frequent screening, annual screening. But for all others, it's at least every 3 to 5 years once they have established negative testing. But this is only for the cervical cancer group. It's not for the other anogenital cancers, as I mentioned. So again, very high risk, and we really need to be making sure that we can prevent most of these. So as far as the treatment goes, the slide says treatment, but there is no FDA-approved treatment for for HPV infection. Actually, everything is directed towards the lesions that are caused by HPV. So if you have precursor lesions, then they may require excision or disruption. And same goes, in terms of warts, you have to go after physical or immunomodulatory treatment. And as I mentioned here, treatment of cervical lesions can cause substantial economic and emotional, adverse effects. And most of them have high mortality. Also, management of invasive cervical and other cancers really requires specialist care, according to the latest HEMONC guidelines. So let's talk about prevention. This is like a dreary topic, and I didn't want to gross you out with all the pictures, so I didn't include the, the cancer pics, but they are really, terrible. So, and I feel really, very, really, very, I think we are in a very unfortunate situation that we have to defend this vaccine as a cancer prevention vaccine when it is the most common STI, and we have a vaccine to prevent against the most common STI, which causes cancer in patients. And it's really, I really feel for those patients. So, most cancer preventing, causing HPV infections can be prevented by vaccination. How cool is that, right? You can prevent all this aftermath by a vaccine. And what more is that right now we went from 3 doses to 2 doses in certain populations, and now there is a talk of even getting a single dose of HPV as a preventive vaccine sometime in near future. We are hopeful. Although the current guidelines in the United States still favor 2 or 3 doses, but we are pretty hopeful we can get to 1 dose. So how cool will that be? You can prevent most of these cancers. We are not saying 100%, but at least you have a good chance of prevention. So again, of course, preventive sexual measures will also help to prevent the spread of this virus. So when we talk about HPV vaccines, till date, 3 HPV vaccines have been licensed by the FDA. So in 2006, a quadrivalent vaccine and a bivalent vaccine were licensed in 2006 and 9, respectively. And as you can see, the high risk 6, 11, 16, 18. 16, 18 are the ones which are high risk and they are covered in both the vaccines. And then in 2014, Gardasil 9, which is a 9-valent vaccine, which covers all these other varieties that I mentioned, is currently on the US market. And I believe this is the only 9-valent vaccine, is the only one which is available right now. And I think doctors' offices are using this. So it is a very highly immunogenic vaccine, and more than 97% of healthy vaccine recipients are able to develop antibodies. And also, it has been shown to provide 97% protection, and which does not wane over many decades. So studies have shown that it provides pretty long-lasting protection. And more so, titers are higher in adolescents aged 9 to 15 years than 16 to 26. So that's also encouraging. And we do have, good immunogenicity as well as efficacy with 2 doses in this age group. They don't have a therapeutic effect on any existing HPV infection. So keep that in mind when you're counseling your patients, that if they have an existing HPV disease, existing HPV infection, then the vaccines would not offer any protection against progression of infection. They work best when they are administered before exposure to any type of HPV that is included in the vaccine. Okay. So the AAP as well as the ACIP from the CDC, they both recommend routine vaccination for all adolescents. The American Academy of Pediatrics, in fact, recommends starting the series between the ages of 9 and 12 years. And I completely favor this recommendation, because when you are seeing a patient at 9, that's just in between it's before the 11-year-old well visit, and it's the time when the patient can also have immunogenic titers. Studies have shown that, and I think if you start counseling parents right from that age, I think it falls in the category of childhood vaccines. And there is I think a lot of discussion around the sexual intercourse and other things that are clouding the discussion of this vaccine in teenage years is kind of avoided. So regardless, the ACIP recommends starting the series at age 11 or 12 years and states that the vaccination, we can support the vaccination starting at age 9 years. So certainly doctor offices can start offering at age 9, but it's recommended by this ACIP to be given at 11 to 12 years. And that's usually what is being followed in most of the states around the country. Like we are usually, offering the adolescent at age 11 or 12 years with the other vaccines that are, with the meninge and the Tdap, which are required at this age. Catch-up vaccination is recommended for all people through 26 years of age. And then CDC also says that shared clinical decision-making regarding HPV vaccination is recommended for some adults through 45 years of age. So as high as 45 years of age can get the vaccine with shared clinical decision making. Through 26, it's usually it's recommended for all people. So as I mentioned, there are the 2 or 3 doses that can be given. So how does that work? So if a vaccination is initiated before 15th birthday, then the recommended dose schedule is 2 doses of HPV vaccine. And if the vaccination is initiated on or after the 15th birthday, then 3 doses of HPV vaccine have to be given. Okay. So when are people considered adequately vaccinated? So they will be considered to be adequately vaccinated if those who have initiated vaccination before the 15th birthday and received 2 doses at the recommended dosing schedule, that is 0, and the second dose is given at 6 or 12 months after 6 to 12 months after the first dose, or any HPV vaccine, even if you did 3 doses in this age group, suddenly, sometimes you don't have the documentation, somebody received 3 doses, that also is considered to be adequately vaccinated. And whoever initiated vaccination on or after their 15th birthday and received 3 doses at the recommended dosing schedule, that is 0, 1 to 2, and the third dose at 6 months, then they are considered to be adequately vaccinated. So whenever they are asking for the school, or the other institutions are asking for the records, this is what is considered to be adequately vaccinated. Now, it's not a mandated vaccine, but it's a highly recommended vaccine. So I would use that terminology in all our conversations. We, as medical professionals, highly, highly recommend this, and for reasons mentioned, before, how bad it can be. So HPV vaccines. If the vaccine schedule is interrupted, we must remember that the vaccine series can be, just picked up from wherever you left. Okay, it does not need to be restarted. And also remember that if anybody received 4-valent or a bivalent vaccine in the past, and then 9 may be used to complete a series. So if the first dose was a quadrivalent or a bivalent vaccine, the second dose may be a 9-valent, and the third dose may be a 9-valent. There is no recommendation regarding additional vaccination who previously completed a series with a bivalent or a tetravalent. You don't need to complete the you don't need to start the series all over again if they received one of those older vaccine. Also, remember that any kind of evidence of past HPV exposure or current HPV infection, abnormal cytologic test results, or any cervical lesions, presence of any warts, etc., they are not contraindications to HPV immunization. Okay, they should still receive HPV vaccine to prevent against any HPV types that are not already acquired. We want to prevent any further damage from any new strains that they may acquire in future. So that's what is the rationale of giving the vaccine. And HPV vaccines can be co-administered with any other live or non-live vaccines. As you know, HPV vaccine is safe. There is a lot of data to show that. And as I will include in the resources also at the end, there'll be a lot of, safety studies have been done, and we have a plethora of data. So more than 135 million doses have been distributed in the United States, and millions of people have received the vaccine around the world. The common side effects are pain, redness, fever, headache, fatigue, etc. And then there are channels to report if there's any safety concern. Then they can go through VAERS and certainly report if anybody has had untoward side effects. The only 2 contraindications for the vaccine are anaphylaxis. So a severe allergic reaction, which is anaphylaxis actually, to a vaccine component or to a prior dose of HPV, as well as anybody who has had anaphylaxis or severe allergies to baker's yeast. These are the only contraindications for receiving HPV vaccine. Rest, everything like a minor illness, etc., do not count as any contraindication of precaution. A severe acute illness or a moderate acute illness is a precaution to vaccination, and vaccination can be deferred till the symptoms of the acute illness subside. And also, pregnancy is considered to be a precaution for the vaccine. So we can defer it until, after the birth of the baby. So these show us the adolescent immunization rates in the United States. If you see, Iowa is certainly a little bit better than the 60s. We are in the high 60s nationally, and Iowa is better. And also, if you see on the extreme right of the screen, female vaccination rates are slightly better than male vaccination rates. Overall, national male vaccination rates are around in the 50s. So encouraging news there, but we need to keep up the good work. So there are several vaccine misconceptions. And as you know, misconceptions can be born by misinformation, which is inaccurate information, which is spread innocently or, inadvertently online. But disinformation is deliberately misleading information, and this is very, very dangerous. And I think this is what we need to be cautioning our patients about. And actually, we are in the middle of the thick right now with this. So how do you effectively address misinformation? So this part of the talk will be focusing on the strategies a little bit, and also different strategies I'll talk to you. But the very first effective tool that we have is called the sandwich method, in which the CDC also says, you start with the fact, You put the warning and the, warning about the policy in between, and then you end with the fact. So also shown here, so state the fact, warn about the myth, explain the policy, and repeat the fact. The idea is that you have to stick, you have to make sure that you repeat the fact in the end so that that sticks. You talk about the misinformation, but just a little bit in the middle. So I just included one example over here. So like sometimes, we know that HPV vaccine is for both males and females. Now, one of the important myths is that, oh, I think HPV vaccine is only for girls, boys don't need it. So then you will say that HPV vaccination is an important tool to prevent cancer for both men and women. Data shows that oropharyngeal cancer is currently the most common HPV-related cancer annually. Okay, and that's the most common cancer occurring in males. HPV is the most common cause of oropharyngeal cancer, and those are by far the most commonly seen in males. And actually, there is no screening test for that. And we are seeing 20,000 cases annually, and that's the latest data. So it's like really happening, and is happening fast. So we really want to prevent that. So HPV vaccination is an important cancer prevention vaccine, and it protects against cancer and therefore should be given to all adolescents. So you begin with the fact, you state the policy in between, give your facts around it, and then you end with the fact that's there. So some other myths, like it's too new. Well, it's been around for a while. It was licensed in 2006 for girls, 2009 for boys, and then ACIP recommendation quickly followed. And the 9-valent vaccine has been recommended since 2014-15. ACIP authorized, all the vaccines for ages up to 45 years in 2019. Then some people may say, oh, is it really effective? You don't know if it's really effective. Well, we already know that more than 97% of the people are protected by it. It produces protective antibodies in more than 97%, which is a high percentage. And then also all these studies listed here have shown time and again that the vaccine is in fact very, very effective. So to remember that provider recommendations are extremely important. So healthcare providers play a huge role in vaccine uptake and perception. I was recently at the AAP Leadership Conference, and Christina knows this pretty well. So there again, the importance of pediatricians was, reiterated. So don't forget your power. Like you really have it, the counseling, and that's what you do. You have been protecting your patients all their lives, right? Right from when they are born. So you are the best advocates for their health. So in fact, studies have shown that provider recommendations are very, very important. Parents who received a high quality recommendation were over 9 times more likely to initiate HPV vaccination compared to no recommendation. So give them the benefit of doubt. Like go ahead and do the right thing, what you are doing for years. I know this is like very, very we are in tough times right now, but then again, we just keep doing the right thing for our patients. Sometimes, whenever you recommend, most likely that will result in acceptance, is what the studies have shown. So there are certain strategies, for our clinic, especially, if we start the vaccine conversations earlier, and I've heard that oftentimes from my colleagues as well, whenever they are seeing their own patients and they are about to have their, babies, those kind of families, parents of very young infants who are visiting their, babies doctors in advance. Those are the, populations in which we should be starting the vaccine conversations earlier. As a specialist, whenever I'm seeing a baby with congenital syphilis in my clinic, for instance, I often just go to vaccines. I say, oh yeah, the baby looks good. We'll do this type of testing and all the related things related to the syphilis diagnosis and testing. And then, when the baby looks good, you have to go to your regular doctor for the vaccines. And if they have not received vaccines, then can we go ahead and give them the vaccines today in our clinic, for instance? So talking about the vaccines at all the possible visits, even you might be a general pediatrician or a specialist, please remember to talk about vaccines at every single visit. That's one thing. And then everybody from the front desk to the exam room to the checkout, if they are all on the same page, that always helps. Everybody gives the same message. And then initiating vaccine conversations with the presumptive approach is usually the time-tested way to go about it. And if they have questions, you need to be very patient, listen to the patients and the parents, and also um, if they have additional questions, then go to a technique which is called motivational interviewing and some other techniques which are also elaborated in the next few slides. So one of them is storytelling. So if needed, then you go to these techniques. But otherwise, most of the times you present vaccination as a standard part of your care. So that's how you begin the conversation. And if a parent expresses doubt, then you give your strong recommendation. And if they have specific questions, then you ask open-ended questions. Okay, what is the one thing that concerns you most? Or can you tell me more about it? So just like recommended here, if a family agrees, then stop discussion, move on with the visit, right? You just say that, okay, we need to give your child the HPV vaccine today, which is child is due for your HPV vaccine today. Or saying something like, she's due for HPV vaccine today, which helps prevent several different types of cancer. Or else, X and Y need their shots for school today, which are tetanus, HPV, and meningitis vaccine. So just including it in the list, or else, just saying that they are due for these vaccines today. And if they agree, then you stop discussion and move on. But if they say, oh, we would like to have, more discussion, we are unsure, etc., then you go on to other strategies, which mainly include motivational interviewing. And I will give you an example. So as I mentioned, motivational interviewing is a very, very important tool and usually employs like a 5-step technique. So you begin with an open-ended question, you provide affirmation, reflective listening, ask for permission to share information and your recommendation, and then you also give the closeout to the parents. So there's an autonomy component, which is very, very important. So you always give autonomy to the parent in the end. So we had this recent publication, showing various strategies to combat vaccine hesitancy. That was published in 2025. So me and my authors from Boston, and I think one of the authors is on call as well here. So um, this was one of the papers. So I think this, and we did demonstrate several studies where they have shown an impact of motivational interviewing, not just for vaccine hesitancy, but for other health encouraging behaviors as well in our paper. So there is an example in this slide. So if suppose the patient or the parent is very hesitant to give the HPV and they are saying, oh, we are unsure. So then you ask open-ended questions. For instance, you may ask, I'm not, so tell me more. Why are you not sure about the HPV vaccine? And then the parent will say, well, I've heard that it might, cause infertility. Then you say, oh, I understand you're concerned. So am I, and then you demonstrate reflective listening. And I hear you're concerned about side effects, but let me tell you, this has not been correlated with infertility. But, if the child does get cancer, then the cancer-related therapies are very harsh and they definitely cause infertility. So, and then you may ask for permission to share literature and the resources. And then you may also ask to share your recommendation. And then the HPV vaccine is effective. And I would strongly recommend it to your daughter. And ultimately, it's your choice, but I'm here to support you in every way. So, just ending the conversation on a positive note and leaving the for future conversations open. So this is further data to show that there is no association of infertility with the vaccine. And then sometimes you may also, delve into storytelling. So they are illustrative examples of personal or others' experiences. And actually, medical professionals also like doing that. And if they have had a relative who has suffered with cervical cancer, or they have given the vaccine to their own kids, they can share those experiences with the patients as well. So my advice, and in general, the AAP also advises that you may want to use these tools and then you may address these tools. I know it's more hard when you just have like a few minutes to go over each encounter and stuff, but then again, leaving the room open for further discussion would be the way to go. So use the next visit as an opportunity. Keep using your power of counseling to talk to the patients about what's really science-backed evidence. It's the truth. It's a protective vaccine, and we are just trying to get them to have the best choices for their children. Also, to help you out, the American Academy of Pediatrics has developed a virtual reality simulation module in association with a British company called Body Swaps, and I think they had a few other collaborations. So I was one of the national subject matter experts to develop this toolkit. So we have certain scenarios in which how to, answer or provide answers to hesitant parents. And actually, this goes through several scenarios and walks you down according to your level of comfort, as well as it gives you different answers for different scenarios. So I think it's a very cool module to check out, and I think we do have it as a link on our website on IYAP, as well as I've included this in this presentation as well, the links. So I think the take home message would be that it's a cancer preventing vaccine. We cannot, I mean, it's a fact. That's the biggest fact, right? It prevents cancer. It prevents the, largest growing numbers of cancers that we are seeing, like, so many cervical and oropharyngeal cancers are still occurring every year, and HPV vaccine can prevent most of them. Again, you should be confident that you are playing a large role in vaccine uptake and perception as a healthcare provider. So continue to use your, power of persuasion and counseling and providing the correct information. And you may employ several methods, including the sandwich method, or we can also talk about motivational interviewing and storytelling as effective conversational tools. And most importantly, leave room for future conversations and discussions. I think that's the most important thing for us to remember. We can have a full session on MI training sometime in future, but that's a topic all by itself, But at least we get an idea of, how to get these conversations going. These are certain resources that were provided at, these are also endorsed by the AAP. And also, I included the link for the simulation module and several resources from the CDC as well about conversations with parents. And with that, I'd like to thank you all for your kind attention, and we can take questions. Penny, thank you.
Thank you so much, Dr. Kaushik, for the fantastic information, as well as like the very well laid out pieces of how to have a conversation with caregivers. Because as you shared, though we are as a state higher than average across the US for rates for HPV vaccine for adolescents, it's still not 100%. So we still have work to do. So like you said, we want to open up the conversation for questions that anyone has. Feel free to come off mute um, or drop something in the chat. We would love to talk about what you're using in your clinics, or if you have questions about how to walk through a specific kind of scenario. I'm curious if anyone has utilized the sandwich method, either for talking about or combating misinformation, or I think, as you also said, utilized it when talking about vaccines for back to school and sandwiching it between um, the required and putting HPV in the middle as a recommended vaccine. Well, we'll be on here for several minutes if anyone thinks of any questions, but that is all that we have for today. I'm dropping in the chat um, the link to our evaluation form. We love to hear feedback, especially to hear about topics that you'd like to have in the future. If it's motivational interviewing, feel free to put that on there. But if there's other infectious disease or various topics that you would like to see, please let us know. We are always looking for the next hot topic to provide for members so that they can get the education they need to go out and see their patients in their clinics. I just want to say thank you all so much for spending your lunch hour with us. And as I said, we'll be here for a bit if you have any lingering questions. I'm going to go ahead and